Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hey listeners, it's Lindsay Smith-Rogers, and today on the podcast, we are looking into the question of pre-diabetes. What is pre-diabetes? What might someone do if they find out they have pre-diabetes? Johns Hopkins professor Liz Selvin is the director of the Welch Center for Prevention, Epidemiology, and Clinical Research. She's also a leading diabetes epidemiologist. She joins Dr. Josh Sharfstein to talk about how to determine if someone is at risk for developing type 2 diabetes and why that matters. Let's listen.
Professor Liz Selvin, thank you so much for joining me today on Public Health on Call to talk about the diagnosis of pre-diabetes. Now, maybe it would help if we started by your introducing yourself to our audience and explaining why in the world I would call you to talk about pre-diabetes.
Hi, Josh. Thanks for having me. So I'm a professor at the Johns Hopkins Bloomberg School of Public Health, and I've spent lots of time thinking about diabetes and pre-diabetes, especially related to best approaches to screening and diagnosis.
I know that you have a tremendous national reputation, and I really appreciate your taking some time to talk. What is this idea of pre-diabetes? What does that even mean?
Good question. So hyperglycemia, or elevated glucose levels, exist along a continuum. And so prediabetes is a term that we use for individuals who are below the threshold for a diagnosis of diabetes, but still have mildly elevated glucose and are thought to be at high risk for the development of diabetes.
Got it. So their blood sugar is high. There's signs that their blood sugar is high in their body, but it's not so high that someone would say, hey, you have diabetes.
Exactly.
Now, why is it important to identify people with pre-diabetes?
Yeah, well, maybe I'll start by saying the entire concept of prediabetes is a bit controversial, actually. And, if you, in some of the popular press and news articles, you often see comments like, is prediabetes real? Is it a real diagnosis? And so there's a lot of, I think, confusion about prediabetes and how to define it. And is it really a medical condition? So that's something I've been thinking a lot of. And I think there's a lot of kind of consternation and discussion about the terminology, which I think has actually resulted in a fair amount of confusion in the field.
Well, that's why I'm calling you to help me figure this out here, because I get some of those questions too.
I personally think prediabetes is real. I actually have a colleague, and he once said that prediabetes is an artificial category with zero clinical relevance. And I completely disagree with that. I think prediabetes is real. I think it's an important designation and it has important clinical relevance. But one of the problems in the field is there's many definitions of prediabetes, and there's actually 5 different definitions that are in current clinical use. And I think that causes a lot of confusion because depending on what definition you're using, you might have prediabetes by one definition, by not in another.
Well, before we get to the definitional issues, I want to go back to what you said on clinical relevance. You had a colleague who said there's no clinical relevance. You're saying there is. What argument do you make to say it matters to identify people who aren't quite at diabetes?
For me, prediabetes is an opportunity, right? And prediabetes is a category of people who are at high risk for the development of diabetes and complications. And, as we'll discuss, it depends a bit on what definition you're using, how we think about it. But all of those categories indicate people who are at high risk for diabetes and complications. So I think that's what's critical. And from my perspective, prediabetes is an opportunity to identify people before the development of diabetes. It's an opportunity to prevent weight gain. It's an opportunity to implement lifestyle interventions. It's an opportunity for weight loss for people who are overweight or obese. I think it's an approach to identifying people early so that people don't develop diabetes.
Now's a moment maybe just to pause and say, we're talking about type 2 diabetes, right?
Correct.
The type of
Correct.
diabetes that's very linked to weight, which is why you mentioned that as one of the interventions. So have there been studies for people who are not quite at diabetes, who are in one of these pre-diabetes spaces that actually shows you can help them? To me, that would be a pretty important question if we're going to say that this is a meaningful category.
Absolutely. And it was a landmark trial called the Diabetes Prevention Program that showed definitively that if you take people who do not have diabetes but have elevated glucose and are below that threshold but are likely to cross it, and you do an intensive lifestyle intervention, weight loss and increased physical activity and improved diet, that absolutely prevents the progression to diabetes.
And that was even a randomized trial, if I'm remembering.
That was a randomized clinical trial. Yeah, really important landmark study. And now we know with all these novel weight loss medications, the GLP-1s, we also now have randomized clinical trials that there are pharmacologic therapies that prevent the progression from prediabetes to diabetes.
So in a way, this is a category that matters because you can do something to help the person avoid diabetes. Got it. Okay, so let's go to those definitions. What do you want to tell me about those?
I mean, without getting too boring and too into the technical details, we have 5 current clinical definitions that are endorsed by different organizations. So the American Diabetes Association, the World Health Organization disagree on what's best for defining prediabetes. So that's kind of resulted in a bunch of definitions that are used in practice. And some are using fasting glucose, and some are using hemoglobin A1C, which is another test of hyperglycemia. And also there is a definition that uses 2-hour glucose, which is a glucose tolerance test, which we don't really use that much outside the setting of pregnancy. So the definitions are fasting glucose of 100 to 125 milligrams per deciliter. That's endorsed by the ADA, and that's a big category. So people with a glucose of 100 to 125, and that's a lot of people. The WHO doesn't quite agree on that 100 cut point. So the WHO defines prediabetes as a fasting glucose of 110 to 125. So that's a smaller group. As I mentioned, there's a 2-hour glucose definition, and then we can use A1C, and usually the category of an A1C of 5.7 to less than 6.5 is used to define prediabetes if you're using hemoglobin A1C.
Even for that last one, I've heard different countries set different cut points for hemoglobin A1C. Is that true?
Yeah, so there was an international expert committee a while ago that said we should define prediabetes a little bit higher, from 6.0 to 6.4, which is a kind of a narrow range. And I guess I will say that, one of the key issues is that these definitions are not designed to overlap. So they identify different people because they weren't developed to sort of identify the same people over and over. So if you're using fasting glucose, you'll get a different group of people. You can be pre-diabetic by the fasting glucose definition, but not by the A1C definition. And I think that's what causes a lot of confusion in the field.
Do they ever say at a diabetes meeting, secretly lock the door and tell people they can't leave until they agree on the definition of prediabetes?
I have been saying that I would like to do that. I would like to take all the experts and put them in a room, because I've been saying for a long time that this lack of consensus has really caused confusion and problems in the field. And we should say, we could weigh in on these different definitions and say when we should use one or the other.
So let's do a thought experiment. There's a big meeting of diabetes experts. The door is secretly locked. When people realize they really do have to agree, they're looking around and suddenly a microphone appears in your hand and you stand on top of a table. What do you say should be the right definition?
Well, I'm an epidemiologist, so I'm going to say it depends. But I really think, one nice thing about using A1C for diagnosing prediabetes or identifying people with prediabetes is that it's a non-fasting test, right? It's a simple lab test, but you don't have to be fasting. And so that can really help in the context of screening and diagnosis. You don't have to prepare for the clinic visit. It doesn't matter what people have eaten that day.
And you could screen people at a community center, for example.
Exactly.
And hemoglobin A1C, if I recall, kind of measures a little bit of a history of your blood glucose over time. So it gives like a little bit of where you live in terms of blood glucose, not necessarily where you're living this instant, but where you have been maybe over the last couple months, something like that.
Yeah, it's essentially kind of a weighted average of elevations in glucose for the past 2 to 3 months. So it gives a sense of kind of chronic hyperglycemia or chronically elevated glucose. So it's this nice, pretty stable test. Your hemoglobin A1C at one time is likely to be the same or very similar to your hemoglobin A1C measured at another time. So it's very stable, it's non-fasting, and it's also highly specific. So if your A1C is elevated in the pre-diabetic range, or especially in the diabetic range, that means you've been having hyperglycemia for a while, and suggests that you're potentially at high risk for developing diabetes if your hemoglobin A1C is in the pre-diabetic range.
Now, what if someone stood up and said, but is it clinically relevant? Do you think the evidence exists for people with elevated hemoglobin A1C, that those studies that you were talking about were really for that group of people in the prediabetes definition?
Yeah, absolutely. I mean, work from our group and work from many other groups have shown that people who have A1C in the pre-diabetic range are at elevated risk for certainly elevated risk for developing diabetes, but also complications. So things like heart disease, kidney disease, and even overall mortality are elevated in people who have a mildly elevated hemoglobin A1C. So we know it's a high-risk group. And so that's one of the reasons I'm a big fan of hemoglobin A1C-based definitions.
And have some of these interventions been tried with this group and shown to help?
I don't know that we have specific randomized clinical trials that are really, gone after specific definitions, but I think it's broadly the case. We can say definitively from randomized clinical trials, if we pick people who have elevated, if they have hyperglycemia, and we do intensive lifestyle interventions or even metformin or other pharmacologic therapy, we know that we can slow the progression of diabetes. One of the big elements of controversy in this field is that while we have randomized clinical trials that show that we can prevent diabetes, we don't have trials that show you can prevent complications because it's just too hard to enroll thousands and thousands of people who are essentially low risk for these complications because they don't yet have diabetes, and then follow them for 10, 20 years to see if they develop cardiovascular disease. So that's sometimes one of the arguments that people use to say, oh, well, we don't know if prediabetes is important. But the problem is we're never going to be able to really do those trials. So we have to rely on the trials where we know that by lowering glucose with interventions, and especially lifestyle interventions, we know that we can slow the progression of diabetes.
You're basically relying on all the evidence that shows that diabetes is harmful.
Exactly.
So let's say somebody's listening who is a little bit on the borderline by hemoglobin A1C. What kind of advice is out there for people who maybe they're not quite in the ballpark of prediabetes, but they're a little bit concerned?
Yeah, I think there's very good evidence that even modest weight loss, even a small amount of weight loss, 5% of weight loss can be really effective and powerful for preventing progression to diabetes. I think one thing that gets lost in the discussion about weight loss is even prevention of weight gain. People tend to gain weight as they get older. So just preventing weight gain in the first place can be really important. So, modest lifestyle changes, eating a healthier diet, exercise, right? Exercise, we know exercise, and weight, strength training and resistance training. All of those things are really good for your muscles and help glucose metabolism. So, diet, weight loss, exercise, all of those things can be really helpful in slowing the progression and preventing the progression to diabetes as people age.
And so as people embrace this definition, it may be that there are more opportunities for people in this higher risk group to, for example, get food as medicine or be able to exercise or qualify for programs. That would be something that could be a very effective investment.
Absolutely. I completely agree.
Well, I actually understand prediabetes a lot better after talking with you, Professor Selvin. So I was expecting to, I'll be honest, but you delivered. Any final comments?
No, this was really fun. And I think my final message is, I think prediabetes is really important, but mostly because it's an opportunity, right? And I think we really need to identify prediabetes so that we can use it as an opportunity to prevent diabetes.
Professor Selvin, thanks so much for joining me. All discussions of arbitrarily locking endocrinologists in a room with epidemiologists were strictly theoretical in this podcast.
No endocrinologists were harmed during this podcast. Thank you so much. This was really fun, Josh.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmond, and Rachel Walsh. Audio production by Michael Bonfils, Matthew Martin, and Philip Porter, with support from J.B. Arbogast, Spencer Greer, and Chip Hickey. Distribution and social media by Rachel Walsh, with support from Nick Moran and Brianna Iacovelli. Follow us on Instagram and Blue Sky at Public Health Pod for more public health takes and special content. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.